It's been great to be here and meet many of you and be part of this with the Podiatry Institute. One of the missions of the Institute is education, and I've been blessed to be part of it. On the website, there's a section that says education, and you click and can scroll down to some of these seminars and some PDF chapters called update chapters, which were presented between the 10-year spans of the textbooks. And if you're interested in some of this, there's a write-up, maybe a 5-page PDF on the specifics of ERAS. This is Enhanced Recovery After Surgery. If you haven't heard of this, you might in the future, as Mickey was saying. There's over 750 hospital systems in the country currently implemented ERAS. So what is it? ERAS is an international nonprofit organization, and the goal of this is to provide a multimodal perioperative approach using the best evidence-based medicine to give us some standard protocols. Okay, the goal is really to improve our patients' outcomes. We want to reduce the length of hospital stay, the complications, morbidity, mortality, and healthcare dollars and expense. Also, we want to decrease the opioid need of the patient after surgery. So, in our day-to-day, we're going from one OR to the next. We're with the patient during surgery, but we don't realize sometimes that that patient's being managed by a pre-op nurse, then they're being managed by a PACU nurse, and each of us has kind of our different roles in their treatment that day, but we have to look at the patients really collectively to make sure that the patient's being managed the most appropriately. One of the themes of ERAS is to reduce physiologic stress. It's one of the big goals here. And this was first introduced back, I believe, in 1997 in Europe for colorectal surgery. And the measures looked at evidence-based medicine on various aspects, spanning from nutrition, fluids, opioids, postoperative nausea, vomiting, early mobilization of the patient, early feeding, and then reducing the length of stay. They showed significant improvements with less hospital stay and decreased infection. This gained popularity over time, and currently there's ERAS measures for all these different subsects through surgery. Now, when our hospital system in Louisville brought this to our attention, introduced this to a group of surgeons, it sounded interesting, but surgeons don't like to be told what to do, right? So it did take a little bit of an open mind to consider some of these measures, and we're going to go through some of them here today. Obviously, we don't see a podiatry subsect, but the recommended measures were, for us, falling under the orthopedic guidelines. So before I was looking at the order sets, I wasn't familiar with all these measures and wanted to look at the evidence that they were using to bring them into our electronic medical Epic system to see if I wanted to use different aspects of this. And there's 18. Okay, some of these may not apply to us because under this orthopedic recommendation set, they are mainly for total knee and hip replacements. So we might not need to think about things like avoiding blood transfusions on most of our routine patients. Some of these other measures I think are almost kind of standard of care, right? Pre-op education of the patient, pre-op optimization, nutrition state, prophylactic antibiotics when appropriate, local anesthetic blocks, short-acting anesthetics, reducing the surgical footprint with smaller incisions when possible, when appropriate, prophylaxis of venous thromboembolism, opioid-sparing approaches, early mobilization, and then discharging the patient when it's appropriate. We don't want to send them home too soon and then they come back the next day, but we want to keep them there as long as that's necessary. So as I look through this list, and as I look through the order sets, I realized that I needed to learn more specifically about the nutrition state of my patient approaching surgery and the opioid-sparing analgesia approaches that the measures offered. And that would be the the rest of the talk, we're going to discuss those two. Surgery is humbling. I think all of us have all been there. You've done the appropriate surgery approach on a patient, but you didn't get the anticipated perfect outcome that you expected. And again, I think our group here with an open mind might be able to take away from some of the work that the ERAS Society has developed here. So let's first talk about the nutrition impact on physiologic stress. When I think of surgery, I think about a marathon runner, somebody who's preparing to run a race. They prepare for that race. It's been said that surgery has the same toll or energy consumption as running for 2.5 hours. When you think about that, that's a lot of energy demand on the body, just like somebody going to run a marathon. These runners don't show up to the race NPO since midnight. They don't show up depleted and not drinking and not energized, right? Snickers taught us that you're not the best version of you when you're hungry. If you don't believe that, you can ask my wife too. But athletes, they train, they prepare. This is Michael Scott before his 5K, loading up with some fettuccine Alfredo. But he knows he needs the carb load for this. If you have the carbs in your bloodstream, we're going to utilize those as the energy stores. And the problem with not having them and being depleted is then we have to break down our muscle to provide the energy stores. There's Michael Jordan. We're familiar with Gatorade and how that's going to replenish us, right, with electrolytes. More recently, even adults are drinking Pedialyte because that's going to replenish us with electrolytes, and what we're missing out on is we're consuming alcohol and depleted. So there's a shift to move away from this NPO after midnight. So this is the new recommendation. Okay. Still no heavy foods for at least 8 hours. That's not necessarily midnight. All the way up to 2 hours, the patient's allowed to consume clear drinks. This includes water, fruit juice without pulp, nutritional drinks, clear tea, and black coffee. If you enjoy coffee in the mornings, this means a lot to you. I do. If I can't have my coffee, I'm a different person. But they can consume this all the way up to 2 hours before surgery, and then they're going to be NPO those last 2 hours. Now, this is actually shown to decrease the risk of aspiration. And you might say, that sounds nice, but my anesthesiologist, he's not going to care about your slide, right? Well, they should, because this was actually published. The source is the American Society of Anesthesiologists back in 2017. So this is their recommendation, even though this might not be implemented currently at your hospital. It could be worth having this discussion with your anesthesiology group, and I guarantee your patients will appreciate this. This is for healthy patients. It's not necessarily for all patients. It's not for our diabetics, those that are obese with difficult airways, or those that are very old and young, and those that are pregnant. It's for non-emergent surgery, but this does apply for general anesthesia cases and also MAC anesthesia cases. As I said before, when we make the surgical insult, we make our skin incision, that's going to release this cytokine cascade of stress hormones through the body. And if we don't have carbohydrates in our bloodstream, the body goes through this catabolism to break down our muscle sources in the liver to produce glucose. And this results in insulin resistance and hyperglycemia. So our patients are hyperglycemic around the time of surgery. Essentially, they're in a diabetic state, and that's the last thing that we want. So the goal here is to not starve the patient. We want to carb load the patient, just like that marathon runner is going to carb load before their big run, so they're prepared from an energy standpoint. This is going to reduce their thirst, their hunger, their anxiety, and their pain by reducing this physiologic stress. And this has been shown to also decrease infection rates, decrease complications, decrease the length of hospital stay by up to 50%, decrease mortality, decrease hospital readmissions and expenses. So what's this look like? This is an Ensure pre-surgery carbohydrate-rich drink. This one's strawberry, and there's some decent flavors of these. There's other companies that have made similar products as well. No disclosures on the talk, by the way. So for 5 to 7 days preoperatively, the patient is instructed to take and drink these drinks. They're each 50 grams, so the night before surgery, they're going to drink 2 of these, so they're going to be carb-loaded with 100 grams. 2 hours before the surgery, they're going to take the clear version of this. They're going to take a 50-gram carbohydrate-rich clear drink. Again, the goal is that they're in the fed state, not the fasted state. This is going to increase the muscle glycogen preoperatively and provide the energy for the body to start to not just perform during the surgery, but to heal and recover without breaking down its own supply of muscle. So you might say, back to Michael Jordan's slide, why not just, supply them with some Gatorade? Well, if you look at the similar fluid volume, this is much higher as far as a carbohydrate standpoint. It's about double or more at much less cost of sugar for the patient. And here's what these drinks look like. They've been designed so that patients can take this drink several days before, and then it's important that the preoperative one is clear, and then some even support taking this through the first couple days or week or so after their recovery. So that sounds good, but this isn't free. When you look online, yesterday I searched this again, it's about $90 for that week of these carb-rich drinks. Not all of our patients can afford that. But if you look at it from overall cost savings, the analysis shows that, and this is only one of the measures, but the costs reduce healthcare dollars by anywhere from $2,000 to about $6,000 per patient. So it's quite substantial, and the next part of this discussion becomes, if the patient's not going to pay for this, is the healthcare system going to pay for this? Is the insurance company going to start paying for this? And some of these measures, again, being introduced by our healthcare system, have been funded, I guess, through the healthcare system. So they do receive their drink. They do receive their 2-hour pre-op drink at the hospital if it's ordered. Part 2 of the talk is how it can decrease the opioid demands that our patients require after surgery. Our surgeries are painful, and when new pharmaceuticals are introduced, there's always a bit of hesitation. Is this going to be as effective as what we're familiar with prescribing hydrocodone and oxycodone? I live in Kentucky, and it's one of the hot spots. This is not just local to where I live, though. Opioid overuse and overprescribing is rampant. Again, this is our ERAS publication on the Podiatry Institute site. From a pharmacological standpoint, the measures surround a couple main topics. Certainly, we want to use local anesthetics and regional blocks before the surgery, so when they wake up, they're not going to be in as much pain, and throughout the surgery, they're going to have less demands for other pharmacologics to keep them stable and comfortable. By prescribing several medications in adjunct to the opioid, we're actually working on several different pathways along the pain pathway. So as the picture shows, Celebrex and Tylenol are going to work on the peripheral nervous system, and then we have gabapentin and opioids working on the central nervous system. And that's what we're going to prescribe. We're going to prescribe not just the opioid, but Celebrex, Tylenol, and gabapentin as adjuncts to affect and decrease the pain along various aspects of that pathway. I like this because we're familiar with these medications. We're familiar with Tylenol. We prescribe gabapentin and Celebrex. This takes a couple extra minutes to write out a couple more prescriptions, but with your EHR system, that can be simplified. These are short courses, and I'll spell it out specifically, but we're only going to do this for about 3 days following the surgery. And this is not set in stone. So if your patient, for some reason, is allergic to one of these medications or had a bad experience with gabapentin in the past, or if they're already on one of these medications, you can tailor it as you see fit for your specific patient and their specific needs. We see the benefits of IV and even PO Tylenol. We see the benefits of oral NSAIDs on inflammation. And no, I have not been convinced that a 3-day course of NSAIDs affects bone healing. That's commonly asked as a question, but a 3-day course I think is suitable and appropriate and does not have those added risks. And then gabapentin post-operatively as an adjunct has been reported in our literature as it can help reduce the perceived pain following surgery as well. So the ERAS guidelines adopted for our patients look like this. Preoperatively, they're going to take 1,000 milligrams or 1 gram of Tylenol 1 hour prior to surgery. They're going to take Celebrex 200 milligrams 1 hour prior to surgery. They're going to take gabapentin 600 milligrams 1 hour prior to surgery. And I order this through the EHR system at the hospital, or I order this preoperatively at my surgery center. On discharge, the patient gets these 4 prescriptions. Traditionally, I wrote them for an opioid, and I still do that, but now they have 3 adjuncts. So I prescribe acetaminophen Tylenol, 500 milligrams, number 18, 2 tabs PO, Q8 hours for 3 days. Celebrex 200 milligrams, number 6, 1 tab PO, Q12 hours for 3 days. Gabapentin, they're going to take 600 milligrams, 1 Q12 hours for 3 days. So as I approached this with an open mind, I was quite impressed. Patients really did seem to do well, and anecdotally we had a great response. So when you see these things, you want to look at it objectively, and one of my residents and I, we prepared a randomized prospective study. This was very simple. We had inclusion-exclusion data, so we weren't examining patients that might be chronic pain patients, those that were, already taking an opioid before their surgery. We tried to categorize the groups so they had a similar comparison, and this was on the up and up through our institution review board. And in total, we looked at 25 patients that were in this ERAS population, and they received the Tylenol, Celebrex, gabapentin with an opioid. And we looked at the control group, similar numbers, 25 to 27, and these just received Percocet 7.5 milligrams. On average, the 4-foot group had a pain level, or a VAS score, where they check from 0 to 10 out of pain. They checked that at 3.7, compared to the control group, it's just above 4. So similar pain levels, but if you look at the ME, that stands for morphine equivalence. And the ERAS 4-foot surgery group had significantly less morphine equivalence required during that first week after surgery. In real terms of Percocet 7.5, this group took 5.8 Percocet 7.5s, where this group took 9.3. Now, we'd assumed that the rear foot group is going to have more pain following surgery, so we looked at them separately. The ERAS group reported on an average 4.5 out of 10 pain, and the rear foot group about 5 out of 10 pain. Again, similar, but the morphine equivalence is significantly less. 146 morphine equivalents versus 200 morphine equivalents. And in real terms, again, a Percocet 7.5. This group in 1 week took 13, and they took about 18. So this has reduced the morphine equivalence significantly, and at that point, I'm listening to what I can do to be better and safer for my patients. looking at this data on some diagrams quickly, day by day their pain's getting less following surgery. This is the ERAS group, and then you can see that they're similar, not significantly different. But if you look at the 4-foot group, especially these first 3 days, you see how the ERAS group requires less morphine equivalents day by day. Again, this is now the rear foot group. Their pain levels are similar throughout, gradually declining, and we see a big difference, especially those first 3 days when they're taking all the medications. These are real quotes from these patients. The first lady said, "I had 2 foot surgeries. This was just such a better experience. My foot stayed numb longer, and I did not have to take as near much pain medication." And that's what I hear time after time. And it's not that I'm probably doing something different with my surgery, it's just this medical management that can really frame the outcome of somebody's surgery. This girl, she says, the Celebrex and gabapentin combination helps so much. I called her requesting more of that. She wanted that, not the opioid pain medication. And a lot of our patients don't like taking opioids. They don't like the constipation, how it makes them feel. But this was suitable enough to help manage her pain, and that's something I hear often as well. And then our last guy, he says, when I had all 4 medications prescribed, I did not even need to take the opioid. So in a similar way, by affecting the pain pathway in different areas, maybe we can get away from overprescribing our opioids. Hope that's something that you can think about, especially in the right patients. And as I said, this can be tailored specifically to the patient you're dealing with. Thank you very much.